Hi, my name is Vaishakhi Shah, and I'm going to present three articles on behalf of my group. The first article is going to be about comparison between the effectiveness of mechanical and manual traction combined with mobilization and exercise therapy in patients with cervical radiculopathy. What is cervical radiculopathy? Cervical radiculopathy is a very common neuromusculoskeletal disorder which causes pain and disability. And traction is a part of the evidence based manual physical therapy management, due to its mechanical nature, type of traction, and the parameters related to its applicability are still to be explored more through research. The aim of the study was to determine the effects of mechanical versus manual traction in manual physical therapy combined with segmental mobilization and exercise therapy in the physical therapy management of patients with cervical radiculopathy. The methodology used for the study was randomized controlled trial. The inclusion criteria were both male and female patients were included in this study. The patients having evident symptoms that they were diagnosed with cervical spine radiculopathy were included in the study. The patients' age ranged between 20 to 70 years. The exclusion criteria were any patients having history of trauma, neck pain without radiculopathy, or patients who were less than 20 years of age or more than 70 years of age. Total number of 72 patients were screened as per the inclusion criteria who had cervical radiculopathy. 42 patients were randomly selected and then placed into two groups by toss and trial method. And out of all of those patients, only 36 patients completed the study and 6 of the patients dropped out during the study. The procedure for the study in the article that was mentioned was that mechanical traction was applied to group A and manual traction was applied to group B, along with common intervention of segmental mobilization and exercise therapy in both groups, and the intervention lasted for 6 weeks. The patient's outcomes were assessed by self-reported NPRS scale and NDI at the baseline and after completion of 6 weeks of exercise program at 3 days per week. The data was analyzed through the SPSS version of software, and paired t-test was done at 95% level of significance to determine if the statistical difference between two groups were significant or non-significant. The results in this study stated that the group of patients that were treated with mechanical traction managed pain. The mean was a pre-treatment was a 6.26 and the mean post-treatment was 1.43. And the disability mean pre-treatment was 24.43 and mean post-treatment was a 7.26. So the mechanical traction was more effective as compared with the group of patients who were just treated with manual traction. The mean for manual traction pre-treatment was 6.80 and post-treatment was 3.85. The results, which you can see in the table on the screen, says that they were more effective for the group of patients treated with mechanical traction, segmental mobilization and exercise therapy in managing pain and disability as compared to the group of patients who were treated with manual traction, segmental mobilization and exercise therapy. And the results were, like I mentioned above, were measured by NPRS scale and NDI scale. So statistically, if we can see in the tables, statistically, both mechanical and manual traction techniques are equivalent and equally significant in group A and B for pain and disability. Both the the p-values for both of the groups were less than 0.05. So to conclude about this study, the patients who has a cervical radiculopathy, if they are treated with mechanical traction, segmental mobilization and exercise therapy, then they will manage pain and disability more effectively than being treated with manual traction, segmental mobilization, and exercise therapy. So the article concludes that mechanical traction is definitely more effective than manual traction. The second article is going to be about comparison between manual traction, manual opening technique, and the combination of both the techniques in patients with cervical radiculopathy. The article is again going to be a randomized controlled trial. The aim of the article was to compare the effects of manual traction, manual intervertebral opening technique, and combination of both the techniques in patients with cervical radiculopathy. The methodology used for this article and study was a single blinded randomized controlled trial. It comprised of patients of any gender having unilateral upper extremity pain, paresthesia, or numbness. The subjects in this article, in this study, were placed into three groups, group 1, group 2, and group 3 using a sealed envelope method. Group 1 was treated with the opening of intervertebral foramen technique, while group 2 received manual traction of cervical spine. And group 3 received both the techniques. 3 sessions were conducted per week for 3 weeks. So the intervention lasted for 3 weeks. The outcome measures were neck disability index, numeric pain rating scale, patient-specific functional scale, and range of motion of cervical spine. SPSS 21 again was used for the data analysis. Then the results of the study, out of 50 patients which were initially screened, 10 were excluded from the study. So 40 patients were included in the study and formed the sample. 17 were males out of 40 and 23 were females. There were a total of 13 patients each in group 1 and group 2, and while group 3 had 14 patients. In group 3, there was one dropout. So like you can see in the figure, all of the groups had 13 patients and one dropout was seen in group 3. In group 1, 8 patients were complaining of sharp and shooting pain. 4 patients were complaining of burning and tingling, and 1 patient complained of deep boring pain. In group 2, 7 patients complained of sharp shooting pain and 6 patients complained about burning and tingling sensations. In group 3, 6 patients complained of burning and shooting pain. Overall, 9 patients complained of neck pain, which was radiating either in any of the right upper extremity, and 5 patients had in left upper extremity. In group 1, 4 patients had constant pain and 9 patients had intermittent pain. In group 2, 12 patients were complaining of intermittent pain and 1 patient had constant pain. In group 3, again, 6 patients had constant pain and 8 of the patients had intermittent pain. Most commonly, it was seen that nerve root involvement, the most commonly that was seen in the study was C6 and C7 nerve root in 15 of the participants. 11 of the patients had C5 and C6 nerve root involvement, and 9 of the patients had multisegmental involvement. 3 of the patients had C4 and C5 involvement, and 2 of the patients had C7, C8 and nerve root involvements. If we look at the pre and post analysis of different groups in table 1, all variables showed significant results and all the variables showed a p-value less than 0.05. Cervical left side in less than 0.05 in regard to pain and range of motion. The outcome measures within each group were noted differently and separately, like you can see in table 2 and table 3 here. Cervical left side bending showed significant improvement in all of the 3 groups. So the p-value for the cervical left side bending was less than 0.05. The discussion of the article mentioned really good points and highlighted a few important points in the current study, in the current literature. The results of the current study highlights that there were improvement in mean and standard deviation from baseline to the end of the intervention in NPRS, NDI, PSFS, and cervical spine range of motion in patients after the application of manual techniques on cervical spine. And the results also demonstrated that both pain and cervical range of motion were improved after the combination of both the techniques. The fact that this is being supported by many of the studies currently, and that no single technique is effective in reducing cervical radicular problems. The results of the current study also depicts that cervical radiculopathy is best treated with more than 2 treatments or at least 2 treatments or multimodal treatment approach, which includes combination of both the techniques. Based on these results of the study, findings have also shown that individual techniques were as effective as the combination, but patients showed better outcomes in range of motions of cervical spine when treated with cervical traction technique and a manual intervertebral foramen opening technique. There were few limitations of this study, such as there was a short intervention time, small sample size, and patients of both acute and chronic conditions were treated in the study. So the conclusion of the study leads us to the point that manual intervertebral foramen opening technique, manual traction, and combination of both the techniques were equally effective in decreasing pain, level of disability, and improved cervical mobility in patients with cervical radiculopathy. The third article's title is Manual Physical Therapy, Cervical Traction, and Strengthening Exercises in Patients with Cervical Radiculopathy. The study was a case series. The purpose and aim of this study was to describe both short-term and long-term patient outcomes for a series of patients with cervical radiculopathy who were treated with a physical therapy management program, including manual physical therapy intervention, mechanical traction, and deep neck flexor and scapulothoracic muscle strengthening exercises. The patients that were included in the study were referred by their primary care physician to rehabilitative services of Concord Hospital, presenting with neck and upper extremity symptoms for more than a 10-month period. They were examined for eligibility criteria. The inclusion criteria for the study was that they need to have a presence of 4 positive examination findings, which were Sporling test, upper limb tension test, cervical distraction test, and less than 60 degrees cervical rotation towards the symptomatic side. The performance and scoring criteria for this test can be found in table 1 on the screen. The exclusion criteria for the study was presence of any kind of medical red flags such as tumor, fracture, metabolic diseases, rheumatoid arthritis, osteoporosis, or any prolonged history of steroid usage. Bilateral upper extremity symptoms were also excluded. Evidence of any central nervous system involvement and presence of Hoffman's sign positive were excluded. Any prior surgery done on cervical or thoracic spine were also excluded. The patients were examined with a variety of self-reported measures, which followed by a detailed history and physical examination, which was performed by a physical therapist. The history which were taken of the patients included age, gender, past medical history, location, duration and nature of symptoms, relieving and aggravating activities, prior episodes, occupation and leisure activities. The physical examination consisted of postural assessment, 72 neurological assessments, including myotomes, dermatomes, and reflexes, cervical, spine, and thoracic activity, active range of motion, which were monitored by the symptom behavior. Segmental mobility testing of cervical spine was also done. Spring testing of cervical and thoracic spine were also included in the examination. An examination of deep neck flexor and scapulothoracic muscle strength was also performed by physical therapists. Self-reported measures which were collected at baseline of the study were neck disability index, patient-specific functional scale, and the numeric pain rating scale, NPRS scale. The intervention which was given to the patients was that all the patients received 4 treatment components: cervical lateral glide, mobilization in an upper limb neurodynamic position, thoracic spine mobilization or manipulation, strengthening exercises of deep neck flexors and scapulothoracic muscles, and mechanical traction was also given to the patients. So, all of this treatment was given in a specific position, and keeping in mind of all the red flags, and it was also performed by physical therapist only. Discharge from physical therapy was determined in combination by the magnitude of functional recovery, resolution of physical impairments, and clinical decision making on behalf of the primary physical therapist, and if the patients have achieved their goals. Patients were asked to rate their overall perception of improvement since the beginning period when they started physical therapy on a scale which started from -7 to +7. -7 being a very great deal worse to +7 being a very great deal better. It was recommended to them that the scores on the GROC were varied between +3 and +1, which represented small changes, and the scores of +4 and +5 represented moderate changes, and a score of +6 and +7 represented large changes in patient status. The outcome measures of the patients were included in case series, which can again be found on table 2 on the screen. So by the conclusion of the physical therapy treatment, 10 patients out of all the patients demonstrated that the treatment was clinically meaningful in reducing the pain and disability as measured by the PSFS scale and NDI scale, which continued to persist at the 6-month follow-up. At the time of the 6-month follow-up, 5 patients scored PSFS of 10, which indicated that they were able to do all the previously listed functional limitations, as well as they could do it before the onset of their symptoms, while 5 others exhibited mild limitations and functions, which were recorded by both PSFS again and NDI. All the patients exceeded this level both at the time of discharge and at the 6-month follow-up, like you can see in figure 3. In addition, at the time of discharge, 10 out of 11 patients rated their improvement on GROC scale as quite a bit better or higher. And at 6-month follow-up, 7 out of 11 patients rated their perceived level of improvement as a very great deal of better, and 3 as a great deal better. So the discussion of the study included that the purpose of this case series was to describe the outcome in a homogeneous group of patients with cervical radiculopathy who has underwent a standardized physical therapy treatment protocol, which includes manual physical therapy interventions, strengthening exercises, intermittent cervical traction, all of these exercises combined. This case series suggested that a treatment approach which emphasizes on manual physical therapy, deep neck flexor and scapulothoracic strengthening exercises, and intermittent traction might be an appropriate treatment strategy for patients with cervical radiculopathy. Only one patient was there which did not exhibit any substantial improvement with this kind of treatment approach which was done in the study. The remaining 10 patients reported a gradual insidious onset of their symptoms, which suggested that the mechanism of injury is the reason for the lack of improvement, which was beyond the scope of this case series, which was also a limitation. So to conclude about this study, we can say that 91% of patients with cervical radiculopathy which were treated with multimodal treatment approach of manual physical therapy, strengthening exercises, and intermittent cervical traction exhibited reduced pain and improved function at the time of discharge and at the 6-month follow-up. So to comprehend and conclude all the three summaries and all the three articles and to summarize them in one sentence, I would say that cervical radiculopathy is a condition which cannot be only treated by one approach. And if treated by one approach, it would not show significant improvement. Cervical radiculopathy is better relieved and shows better improvement when treated with more than one approaches and treated with multimodal treatment approaches, which includes physical therapy, strengthening exercises, manual traction, or mechanical traction. Also, to compare mechanical traction and manual traction, one of the study that I presented described that mechanical traction is more effective in cervical radiculopathy. So that should be the approach while giving the treatment to the patients. Thank you.